And again, it just comes down to numbers. The more people that we can have, people are ultimately individuals, and how Victoria conducts herself as a student isn't just because she's a student of color, because she's a female student. It's because she's who she is. And the more we can have diversity in the classroom, the students can understand that, but it's, the faculty should already be there. We really should already be there cognitively in order to be able to start to bring that into the classroom and have students accountable for it.
Some things you wish faculty, staff, or other students understood about your experience.
Okay. One thing that's often overlooked is that this is recent history. Within the past 100 years, these events have happened within Black community, neighborhood community, a bunch of marginalized groups. And so we often overlook the fact that this happened 30, 50, 40 years ago, and that personally, for my culture, there was laws against practicing our ceremonies, our methods, dances, everything. And so there's a lot of history that was lost because we were sent to schools, just we weren't able to do what we needed and wanted to do. And so like I said, it's overlooked that we're missing out on a lot now, and we are slowly building back up, and that we need a lot of support. It's not easy to access some archive of our history because there isn't really that many. A lot of it has been erased. And so kind of just what I'm saying is that I wish people understood the hardships of not only my culture and my people, but the culture of different people, different groups. And there should always be that thought in the back of the mind of how can I get into the shoes of this group? Vaguely.
Yeah, no, that's a great answer. A couple of things that I would share about this are, I was temporarily disabled, physically disabled last winter right after I started school, and it was very helpful that I could go to all my classes online because I was in bed and not able to walk. And so one thing I hope is that, thanks Joshua, is that we can continue to incorporate some of those kinds of access things. I'm also a parent. Like, I have class at night and my kids are downstairs doing whatever they're doing, right? Like, for me to have to figure out where they're gonna go and how they're gonna get dinner and then get to a class and all of that is a lot. And I'm not a single mom, and that, for a single parent, that's an extra burden. So I think those kinds of access things are really important to consider. Along with other kinds of disability access. It was a lot of extra work to get our ASL folks here today. And that shouldn't be the case. We should standard practice have ASL. In your Zoom classes, standard practice, have closed captioning. You can turn it on in some of those WebEx applications. If you need technical help, you can ask Joshua. People need, and asking your students before your class starts, what are your access needs, What is your life like? How can I support you? And I know that, your job is not to necessarily be someone's emotional support person or caseworker, but you can have some understanding of kind of where they're coming from, A couple weeks ago when it was all this anti-trans legislation, I was in a constant state of panic attack. Am I gonna have to move my family because I'm gonna be put in jail for affirming my child's identity? And that's like, and then you gotta go to class and talk about like, program evaluation or whatever. It's like, your brain is not in it, and just to have some awareness of that sort of thing, I think is very, when stuff's happening in the world that impacts people's, when there's another murder of a Black person by police, like, acknowledge that, or make some room for that, or check in with people, and like, that kind of stuff, like, humanity, like, this is about being better humans, And the other thing I really wanted to say is that it takes so much courage for a person in a down power role to say to a person in an up power role, something you are doing is hurting me, or something you are doing is wrong. Especially a person with a PhD, or who think they know everything about everything. So when a student comes to you and says, or you get in an evaluation, some kind of feedback, I would just encourage you so much to try to view that as a gift. It is such a gift that somebody takes the time and energy and emotional bandwidth to try and help you understand something more. And it's so commonly experienced as an attack, and then there's like this defensive response, and then it is harder for the person who's coming to you with feedback. And, that's not what we're going for. Like, I don't think that's what anyone really wants. So just to really reframe feedback as this amazing gift that takes so much courage for people to bring to you. Yeah, I don't know if anybody else wants to, we have a couple minutes left, but if there are any other, things that you thought of that you didn't get to share, or that you'd like to say.
I was just going to say, I do want to applaud the CHHS faculty though, because it's not everybody that I've had experience with. I've had really great experiences with a lot of faculty members, and I felt like the most comfortable with some of my CHHS professors than even in my prereqs. So I do want to say thank you for that, because I do feel like I love that this college addresses DEI issues. That's not really addressed on other areas of campus. I was never even really brought up as in like general areas of campus. But here, I like that we actually focus and want to improve these issues and are addressing them. So I have definitely had professors support me through this journey, because I would not have made it without the professors or the help of others. Even the advising office, even just my holistics class, I have one semester, I still talk to that professor. So it's just that you being supportive, understanding, just being open to letting students come to you and just talk to you. Y'all are doing great. So I just want to say that, because a lot of students do feel comfortable to talk to you. So I just want to say that. It's not all, it's great.
Kind of going off of that, I'm not familiar with this department too much, but I am part of the College of Arts and Sciences. And so from what I'm hearing, it sounds like you're doing an amazing job. Like Victoria said, there's a lot of engagement and awareness in this department, and that is lacking in other departments. I know that I have a requirement for diversity and inclusion class, but other than that, there's virtually nothing else. And so there's a lack of it in a lot of areas of this campus, but it sounds like this department is going to be a lot. So thank you for doing that.
Yeah, and two last things. Did you want to say something? Okay. Two quick last things. One is, you're here, and that probably means you really want to know about these things and you're engaged. And then there are a lot of your colleagues that are not here. And I would, as in finding ways to encourage each other, to continue to grow, to continue to learn. I know that it's complicated. I know that there's personalities. I know that all of that is true, and it's really important, because of the way it works, even though this there may be a desire for faculty, say, to integrate all of this stuff into their curriculum. It's going to be up to them. And if it doesn't feel important to them, they're not going to do it. So we need to help them understand why it's important. And the other thing is, Megan and Victoria and I and several others are on the student DEI committee for CHHS. We're interested in any other members. So if you have students that you think would like to participate in that, you can connect with Dr. Dennis and she can connect with me, or you can email me, and we'll loop them in. But it is 11:15 and 9 seconds. We're done.
Walking over from the table over. We appreciate you. And we are interested in what you have to say. You do have a voice in the College of Health and Human Services, you and all the other students. And so if you need to talk to somebody, you just find me. Just find me. Because we are committed, we are interested. So you just find me. Okay, all right. We've got a break. There's snacks still, eat. There's a raffle. There's a raffle for a tablet. There's a raffle for a book. And so that's coming up next. All right. Almost done, you all.
Dory.
Have 2 raffles, and even if you're not here, you're going to win. Okay. So Dean, put 2 names.
2 names. What's the first name for it?
Do you need to say something about your Okay. This is Rob Meemick. This is Rob Redmond from Meemick Insurance. I want you all to put your hands together and thank him for the tablet. So thank you for that. And so the first name you pulled, Dean, is for the tablet. Unless it's for me, and then it's
Oh my goodness. You would not believe who won the tablet.
Okay.
Was our amazing leader of all of this, Dr. Betty Dennis.
No, I can't put the tablet. No, I can't.
This got bumped and it's way crooked. I'm going to, yeah. So I'm going to
But you put your
rotate
name
it so that you can actually get some
Rob.
adjustment out of it.
I always put my name in
Oh,
because of Rob.
where's the
Put
lock
somebody
for the
else.
rotation?
Put somebody else.
For spinning it?
Rotation lock.
Pick 2 people.
Here?
They can't be.
Nope.
Okay, we'll try this again, Betty. Karen, Joe,
James.
Karen James,
Karen Royster James.
Karen Royster James. She must
And,
have been here and
okay.
whether she's here or not, right?
Yep, we'll get it to her. Wonderful. One more.
Thank you so much.
One more.
Okay, one more, and this is for,
The medical bondage.
and this is for Claire Ward.
Yeah.
Claire is a physical therapy student, and this is our physical therapy cohort class of Dr. Yvonne Jackson.
Yay!
See?
Of course, it would be my name, but I didn't want it to be my name. Like, oh my God. Oh my God. Oh, did they? Oh, yay! Well, good. Give it here. The tablet. You're Karen James, right? I guess that's my one.
Oh, you are? Okay, I wanna, okay. I thought you was, I think you was. I got one. Oh, you got it? Thank you.
All right.
I know, so
I have no idea why. It's virtual. It is virtual too, so then. Okay. Well, at least. Yeah. Who knew? Yeah. Yeah.
Well, it's my second year at Western, but I went to community college beforehand. So I went to Grand Rapids Community College. But yeah, it's my first year, like, how long have you been?
Yeah, for now. I'm from here.
Yeah.
Awesome. She's like, oh, I said no pressure, but as long as I have to. She's so excited. She makes it. Oh, you got it. I thought I can teach that.
Good morning. Good morning. It's not quite 11:30, but I just kind of wanted to get everyone calmed down because we have a very, very, very tight 1 hour schedule. And we have some very, very important people that we want you to meet. And so to end our moving toward health equity, we brought some community members to you. So each member will have 10 minutes to give you a little overview of their organization. And so the question we pose to them is to give a general description of your program, the underserved population that is served, the barriers, the barriers that the clients encounter, and if time, support your clients' need to improve their health status. Okay? And so today, listen on, we'll continue on. We have Dr. Sharmini Alori from Street Medicine, Kalamazoo. We have Velma Hendershot from Intercare Community Health Network. We have Ms. Joy Presbury representing Kalamazoo, Cradle Kalamazoo. And we have Dr. Doris Robotis doing health literacy. Okay, so without further ado, we'll get started.
Good morning. Thank you for having us here. My name's Shravani. Shravani, or is it hard to hear with this? Okay. My name's Shravani. I'm the director of street medicine in Kalamazoo. Street Medicine Kalamazoo is the name of the organization. I'm also an assistant professor in the Department of Family and Community Medicine at WMed. Once we get this PowerPoint up, I can get started. So the Street Medicine Kalamazoo is a fairly new organization, new division at WMed, and it's a part of the Department of Family and Community Medicine. But it is really interdisciplinary, where we have all like fields of medicine kind of represented in the team there as well, but officially on paper, the Department of Family and Community Medicine. So we have a little over, we think we have over 1,000 unhoused individuals living in Kalamazoo, and at least 200 of these individuals live unsheltered, meaning they live on the streets and encampments, but not in places meant for human habitation. But it's not like because of these numbers that we started our program, Street Medicine, last year, but because our healthcare system overall does not do a good job of taking care of our unhoused population, of our underserved populations, really. And we see this in the form of like increased mortality and morbidity in our unhoused patients. So some of these data points, like in Boston, they found that unhoused individuals were 4 to 10 times more likely to die than the general population, and found that the status of experiencing homelessness, being unhoused itself, is an independent predictor for mortality. And a lot of times, like when we see patients that are unhoused, like so many times in the healthcare system, in offices, in the hospital, yes. So many times we label patients as non-compliant, non-adherent, as not prioritizing their health, and therefore there's nothing more that we can do for them. Like we're giving them everything that we have, all of our resources, but they need to take that step. And really, it's just a lack of we do this kind of without really fully understanding what the barriers to access and care for them are. And that's kind of where programs like Street Medicine are valuable to kind of better understand these patients and improve some of these statistics, like these high morbidity and mortality in this patient population. So overall, like the patient population that we work with they're very difficult to treat. And the way they're difficult to treat because they have so many barriers or like so many difficulties that they're facing in their daily lives, from finding a safe place to stay, making sure that their belongings are safe as well from being stolen, making sure that they have food for the day, making sure they have food and water for the day. And then trying to address like all the different things that they may have going on, like legal issues and so many other things that often like health takes kind of a backseat, and our healthcare system in the way that it's structured, with like patients having scheduled appointments, needing to come in for scheduled appointments to access different services. The way that it's structured often excludes our unhoused, and not just unhoused, but like quite a few populations. But since we're generally focused on the unhoused population, that's one that I'm mentioning right now. But they're generally excluded from the healthcare system. And it's not necessarily that and because of how it's structured. So what street medicine focuses on is providing care on site. So we go out to people and see them there, do entire clinical visits there, where they're staying, like at the encampments, at the shelters, or sometimes in parking lots and on the street. So wherever they are, we take all of our clinical supplies and go and see them there. And we also, a lot of what we do is coordination of care. So making sure if we're getting them to figuring out how are they going to get to these appointments? Do they have transportation? Can we get them some sort of transportation? Can we get them to a place that's actually easier for them to access? Is there a place closer downtown? A lot of these things get missed in our general clinical visits, even though we have care coordinators, care managers, and social workers, and everyone. Like, there are things that often get missed, and it's like it's one of the most a lot of our time is spent in care coordination for patients, figuring out how to get them their medications if they're not able to get to the pharmacy to get them regularly. And we also, the other big piece of what we do is frequent visits. So these aren't necessarily patient-scheduled visits. They can always call and request to see us if they have something going on, but we go out to all the encampments, we go out to where we know people are staying, we go out to the shelters to make ourselves available and see. We always say hi to all the patients that we know, and it helps us pick up when they're not thinking so much about that wound on their foot that looks a little bit infected, but it's not bothering them as much just yet. But at least we get to detect those things a little bit earlier. We get to follow up with if they have hypertension or diabetes. We get to check in on them and see, do you have your medications? Have you been able to take them? How's it going? And be able to check up on that really frequently, on like a couple times a week to at least a weekly basis with most of our patients. So, like I said, street medicine is about going to the people, and it's healthcare delivered directly to those people. It's the definition of street medicine is healthcare delivered directly to those people that are living on the streets, that are living unsheltered. We take care of the unsheltered population, as well as we also set up at the shelters, at the drop-in specifically, and at the warming center and stuff in Kalamazoo, to be able to and see people that are both sheltered and unsheltered. But our focus is on the unsheltered population, so people living on the streets, people that may be living in motorhomes without electricity and water, and in other locations like that, because they're the individuals that have much higher mortality, 10 times that of the general population. They're the individuals that we don't usually see in shelters, and we don't usually see them come to clinics. The only place that we'll see them is often in the hospital when they get admitted. So our goal is to kind of capture them early, see them early, and kind of re-engage them in the healthcare system that they've been excluded from. And so we started pretty small. We started pretty recently as well in January of last year. And we started off just kind of providing donations. It was a kind of a collaborative exercise between me as a resident, when I was a resident in family medicine, and some of the medical students, as well as some faculty at WMed. where we started going out to the encampments and just walking around with a backpack full of socks and water and hand warmers and stuff in the middle of winter and just handing out donations and checking in on people and seeing how they were doing. And as we established ourselves in the community and established trust with the community, we started providing more medical care. And we received a lot of grant funding over the past year that's really supported our program and supported us in expanding our clinical services, where right now we are essentially a mobile clinic without a mobile unit. So we take cases of supplies with us to be able to provide care on site, with whether it's just counseling patients versus actually prescribing medications, or even doing procedures on site and stuff as well, anywhere from like things with joint injections to doing abscess drainages and everything like that. We have a setup to do it wherever we see patients. So. I have our phases of development up here, but like over the last 6 months, over the last year, actually what we've been doing is a needs assessment of the community, trying to understand what resources are out there, what are the different organizations, different outreach organizations the public health department already providing, and then where do we fit in this picture. And then of course, like through like engaging with the population, we started building trust there as well, and then started expanding with more personnel, more medical students and residents, and then expanding around the different clinical services we're able to provide, and also just starting to partner with the different community organizations so they know that we're available and we can each use each other as a resource. And over the past year, we've seen over the past 9 months, really, we've seen nearly like 900 patients. Meaning 900 clinical encounters. We have 245 unique patients that we see, and there are a multitude of, like, we've gotten 5 grants over the past year that have really helped us grow to where we are today, and we've started forming a lot of community relationships with Kalamazoo Harm Reduction, like the syringe exchange program here, as well as the hospitals and like the different clinics in the area. I work at Family Health Center, so Family Health Center has been like one of our partners through this as well. And really, like, one of the things that I would want you guys to think about is what we hope to develop with street medicine. We're in the beginning phases where we kind of started to set up like street medicine as a clinical site, and we're providing regular clinical services to the unhoused community. So twice a week we'll go out, and sometimes even more than that if there are any urgent needs. But for this to be successful, for us to actually start overcoming some of the barriers to care that patients face, this needs to be an interdisciplinary exercise, where we have we have so many resources in Kalamazoo. Like within WMU, we have like the School of Social Work, all of the allied health schools and students as well. And like eventually we want to get to a point where all of us are kind of working together to make services more accessible to the unhoused community. And that's the ultimate goal, and that's what we're working towards. And hopefully in like presenting to you guys today and letting you know a little bit about street medicine, we can see more involvement from here as well. And we're working on, at the medical school, we're integrating it into the curriculum. So for residents, for medical students, street medicine will be integrated into the curriculum. And we hope that that opportunity can be available throughout our colleges here too. I don't know if I've exceeded my time. I tend to speak. Okay, are there any questions? And I'll give Yvonne I forgot to put my contact information up here, I apologize. But it's just shravani.o'leary@med.wmich.edu. So if you guys are interested in coming out and seeing what we do, if you're interested in. And if you're interested in like actually partnering and doing more as well, we can always we're always open to talk about that and to take everyone out with us too.
Thank you. Any questions?
I think just one class that focuses on practice group work, and I wonder if you would have something for a school social work, like a student group, like a project that students approach to, or things that they could do of service.
Yes, definitely. So I spoke initially with a few, Marianne Trillett from the School of Social Work and Dr. Diacono, I don't know how to say her last name. But we definitely have opportunities where like right now we're doing a lot of care coordination, and I can definitely integrate students into that, where we can have little care teams, and have the students working with us on some patients, to help get them more resources in the community, and I think it would be a good experience for them as well, to be able to do that, so definitely.
Question. I was just wondering, do you currently use any nursing staff from WMed to go out and do actual visits currently?
We don't currently, can.
Because I'm from the nursing program, so I'd love to talk to you about opportunities having nursing students participate.
Yeah, we can. And I mean, that would be great because like it's the limiting factor for us really is the personnel and having like more, having like students from social work, having students from the nursing school involved would really help us like provide more care. And it would be a good educational experience, all of it together. But.
I'm interested in knowing how long individuals, what their retention is. How long do they stay with the program? You know, because okay, excuse me. So I'm curious about the people that you have working with you. I know often, you have people come in, they're with the program, and then they leave because they move on. So it's a quick turnover. And so I'm curious about, how you build that trust, and how do you build that trust, perhaps if you don't have protection.
So that's a really good question, actually, because that's the nature of having students or residents involved in programs like this. There will always be that turnover. They'll only be there for a couple of years, and then they're moving somewhere else. And the consistency has been actually in the consistent faces that they see are us, is like my face and the face of the other faculty that are involved. And really that's how we've built that relationship over the past year. And what we've created is like, they kind of trust our team now. So our patients tend to go like, one of our patients told me, you always bring out good people. So I'm happy with whoever you have seeing me. And like, that is one of the ways that we continue to like maintain that trust, just, because we built an image as a team, and then we have like consistent faculty members as well. And the way that the care teams, like if we were to have more people, would be built is you'd have a group of students, residents, and students from different schools working together on a set of patients. So there would be like a consistent team taking care of it, and there should be like pretty clear handoffs between those teams so that they can continue the care effectively, where every time there's someone new coming, it's not like the patient has to tell them their story all over again as well.
For the balance show,
go to, and come up. One thing I always do is I always begin to introduce myself. So I know some of you may not know me. I apologize. I should have introduced myself. So I am Yvonne Jackson. I'm sorry. I am assistant professor in the Department of Physical Therapy. I'm also a part of the Interprofessional Education Committee and the newly formed DEI Committee within the department. And I'm also a member of the Racial Justice Advisory Committee with the university. So that's kind of how I kind of got in all of this. But that being said, we're going to move on to Joy with Cradle Kalamazoo.
Hello. It's working. How are you all today? Good. Well, my name is Joy Pressberry. Pronouns are she and her. I recognize I may not be the name in your program, but nonetheless, I'm excited to be here with you all on behalf of Cradle Kalamazoo. So before I get started, how many of you have heard of Cradle Kalamazoo? Awesome. Well, then you all know what the problem is. So before I get into what Cradle is, I want to just talk to you about what we're seeing within our community. And it's simple. Black, brown, and poor babies are dying at a disproportionate rate, especially when compared to their white counterparts. So when we take into account infant mortality, if you're unaware, the infant mortality rates are often used as a measure to reflect our community's overall health. So when we take a look at infant mortality, it's giving us a gleam into what our community health looks like. And so what we're seeing here is that we know there's a goal out to 2025, Healthy People 2025 goal of having a nation infant mortality rate that of 3.0. Well, we want to have our infant mortality rate here in our community to be reflective of that, but for all populations. So we're seeing that our white higher income families here are experiencing infant mortality rates at about 3.2, which is near the goal. We recognize that not all mortality can be eliminated, right? There are some things that are out of control, but we can do our best to eliminate and reduce things that are not purely medical. So again, we're seeing infant mortality rates in our higher income families that are white at about 3.2. But then when we take a look at that same infant mortality rate for our lower income white families, it's nearly 5. And you're like, okay, well, what are you getting at, Joy? Well, we want to recognize that for our infants of color and our families of color, that rate is not comparable. So when we take a look at the lower income families of color experiencing infant mortality, that rate is nearly 15. And for our higher income families of color, it's about 10.5. So people often think that, education or income are protective factors to these outcomes we're seeing in our community. And I'm here to tell you that it's not. Again, if we take a look at these infant mortality rates for our higher income families, especially those of color, it's 10.5. That's 3 to 5 times that of their white counterparts. So if you're not into numbers, if charts aren't your favorite thing, and I want to talk about relative rate, or again, that disparity between these populations, right? So we're seeing 2.5 relative rate, which means our families of color, our higher income families, are 2.5 times more likely to experience infant mortality than their lower income white counterparts. And again, what I was getting to, if you're not into charts and numbers, here's just another stark imagery to display the disparities that we're experiencing here in Kalamazoo County. And again, noting that things like income and education are not protective factors for these outcomes. And so a few years back, we actually surveyed about 10% of our birthing population. So we took samples from both of our birthing hospitals here in Kalamazoo County. And what we were finding, right, you were like, why is this so, Joy? What's the underlining of these issues? Well, we're finding that our women of color and our low-income families are experiencing regular in our community experiences of disrespect, dismissal, and discrimination, particularly with their providers in our hospital settings, but also in their daily interactions throughout our community.
And so again, if we think back to those previous images, we know that the experiences of our lower income people of color and white people, that they're experiencing higher infant mortality rates. And it's reflected in this chart when we consider the reports of discrimination and disrespect in our community. The people of color in our community, rather they're, and we use private and Medicaid as a proxy for income, but regardless of those income statuses, that they're reporting these experiences regularly. And again, when we compare that to their white counterparts, we see that they less frequently experience those things in our community. And what's important about this? Why did they ask us to talk about this, right? It's because we know that these experiences with our community are going to lead to hypervigilance, always having to be on your toe, having to be prepared to enter a space, regardless of what you're there for. And it becomes toxic to your health and your health outcomes. So when we think about the pregnant and parenting folks who are taking up services within our community, we know that it's negatively impacting their health and the health of their infants, or that the infants that they're caring and delivering. And what is that going to lead to? Regardless of your profession, if you're physical therapy, if you're a physician, whatever place you have in the care provider team, it's adding mistrust, which we know is already running rampant within our communities. And it's just adding to those experiences for the people that we are aiming to serve. And so we talk to people, right? It's one thing to just assume, but it's another to hear it from the mouths of the folks that we're serving in our community. And so some of the common things we were hearing, particularly about their interactions with the care systems here in Kalamazoo, is to respect me, right? R-E-S-P-E-C-T. I know y'all know it, right? Respect me, my body, my knowledge, my decisions. Other things, just listen, right? Be attentive, active listening. Find ways to help me understand. Sometimes there are imbalances that happen in these conversations, right? But ensuring that the folks that you're speaking with and that you're seeking to serve are understanding and are walking that journey along with you. Don't judge or don't assume, right? You walk into these spaces, don't already come in with an assumption. Have that conversation. Build that trust that Dr. Lurie was alluding to earlier, even if it's in a medical setting and not just on the street. And take the time. Time is money nowadays. So you need to take the time to interact properly with the people in our community. And so again, we talk to people, we listen to their words. They have things to say about the care that they're receiving and how they interact with the services within our community. One of the things, and I won't read them all to you all today, but one of the quotes says, "And listen to us. Even though it might seem crazy or stupid, just listen." And so now let's get into Cradle Kalamazoo. What is Cradle Kalamazoo? Well, it's a group of interprofessionals, and we have folks from grassroots organizations all the way to our larger institutions, our larger health institution. And the goals of this multidisciplinary collaborative group is to reduce infant death, eliminate those racial disparities that we talked about earlier, right? I shouldn't be more prone, or I shouldn't be having these rates differently than you just because the color of my skin, or just because of where I reside, or just because of some of these factors that everyone experiences, those social determinants, right? So this group is seeking to reduce the infant death, eliminate racial disparities in infant mortality, and to do this by promoting respect for our families, our women, our pregnant and parenting folks, and all of the folks that they encountered. And so with the goals of reducing infant mortality, we intend to do this by ensuring health equity and cultural competency of all of the programs, policies, and providers, and all of the services that folks are uptaking in our community. Building a perinatal home visitation network, which is an evidence-based program that can help to come into some of these trajectory pathways that people are living in. And coordinating and streamlined processes. Dr. Laura talked to you all a little bit about care coordination and its importance here in our community. Promoting and providing education around infant-safe sleep. Earlier, I previously mentioned some of the mortality that we can avoid, but there are many that we can avoid, like safe sleep-related deaths. And then promoting spacing between pregnancies and providing education around reproductive health, which we know is extremely important. So I'm actually a researcher, so it's always important to make sure that the things that we're saying and doing align, and they align with strategy. We don't want to just throw things at folks and expect them to react, right? So again, if we're returning ourselves to that problem, black, brown, and poor babies are dying disproportionately here in our county. Some of the causes are the fragmenting systems of care. Again, so how are people accessing and seeking services? Is it coordinated? If I am an unhoused person, how am I accessing things, right? This is important, not just for people on the street, but for the pregnant and parenting folks in our community. Stress resulting from poverty, racism, and discrimination, those deep-rooted things that exist in our systems, right? So not just looking at individuals, but our systems and institutions. The lack of opportunity and access, and then an inaccessible and culturally incompetent health language that's utilized in these spaces. So for identifying some of these causes, and we actually use the fetal infant mortality review as a way to, for Kalamazoo County, as a way to identify these causes and the linkages behind it. So I forgot to mention that I actually coordinate the fetal infant mortality review for our community. Oops. But when we're thinking of the strategic objectives associated, Cradle Kalamazoo is seeking to coordinate the perinatal home visitation network. Again, home visitation is an evidence-based intervention that can help with the outcomes and the experiences of the family, the pregnant person, and their support system. So it's really important that these are resources that we're highlighting and elevating within our community. Incorporating health equity into clinical, social practices, the policies and structures. Again, getting at those deep-rooted things that we know exist. Providing reproductive health education, providing safe sleep education, and then advocacy and systems change through our public policies. And so just to highlight some of the ways that we've been kind of victorious in working at this issue that's plaguing our community is we've been able to shift prenatal care entry from 19 weeks to 9 weeks. So we were finding that pregnant persons were not getting into care as early as they needed or as early as they could. So we've been able to shift that. We've also been able to shift birth weights, particularly for our women of color. We know that and similar to the infant mortality rate, women of color experience low birth weights and poor birth outcomes at a higher rate than their white counterparts. So we were able to have a 20% increase in that. We've been able to provide thousands of dollars of direct services and needs to our client. This was important, extremely important during the start of the pandemic for our community. When we've been able to present infant mortality disparities and advocate in housing spaces. Dr. Lori talked about unhoused folks within our community, and pregnant persons are among some of those unhoused folks. We were able to recently launch a universal referral process to address some of the uncoordinated care that's happening with our community, making sure folks are getting to the services that they need to without necessarily having to disclose something that they don't want to disclose, right? Why do I have to identify that I'm struggling? If the resource exists, which we know it does, why can't you help me get to it, right? So we've implemented a process to help address that gap. And then we've created a community voice panel, which is a standing group of community members here that we go back to regularly, making sure that they're involved in the policies and implementation of programs here in our community, right? Don't just give them a survey, but are we doing this right? Is this actually what you need and not operating off of our own assumptions? So Cradle Kalamazoo, again, is a group of dedicated folks from various agencies. I'm so happy to see some of the partners here in the room today. And we know that this is not just an individual problem. So it's really important for you all, especially the students who are stepping into their professional roles, to understand how you can play a part in improving the outcomes of our babies, of our family, and everyone here in our community. I know it was a lot, but again, I'm Joy, and I'd always be happy to answer any questions for you all. And if you're interested more in Cradle Kalamazoo and some of the specific activities that we do here in the county, you can always email the Cradle Kalamazoo email and visit our website. We have an exciting new health equity video that we just put there, so thank you all.
Questions for Joy?
Next, we're going to have Dr. Doris real quick. So she doesn't have a PowerPoint, so if you want the mic.
Okay, so I'm Dr. Doris Robotis, and I work with the Kalamazoo Literacy Council. One of the big things I do is I run a Health Plus English program in the summers for refugees and other English language learners, where we teach both English and health at the same time. I do that in conjunction with a local community literacy center in a church, the Kalamazoo Literacy Council, and the Kalamazoo Refugee Resource Council. So we have been going for about 5 years, and we have between 70 and 90 people come every year, including the last 2 years, which were totally online. It took a lot to get some people online, particularly people who getting people the technology, but also trying to talk people through that technology who did not understand English. So that was a big, an interesting barrier to overcome for us. I wanted to talk a little bit about not just that program, but health literacy in general, and some of the other activities in health literacy. But before I get into that, this year in the Health Plus English program, we're going to be covering health and safety issues. Things like fire safety, and heat exhaustion, and hypothermia, and things like that. And we also are going to, that portion of the program is run by the English language teachers, but we also are looking for volunteers to help announce classrooms, and also to help with a program that's going to be run by volunteers on how to access health information online, reliable health information. So we are looking for volunteers in those areas. I also work with, moving on, I also work with the Kalamazoo Literacy Council in some of their programs. There is an advisory group between the Western Michigan University and the Kalamazoo Literacy Council. And most recently, we have been working on projects in the Edison neighborhood, which is actually where the Literacy Council is, at Goodwill. And the most recent thing we're looking on is turning that neighborhood into an education neighborhood. And we're working on having educational elements around the neighborhood, having a trail with like a wellness trail that would include literacy as part of that. So there's also a lot of opportunity to become involved in that through Western, and we're always looking for people. There are people, there are interns and residents from Western, residents that are fellowships from faculty members that work with the Kalamazoo Literacy Council. And we have nursing there right now that's working on Wellness Fridays. So there are plenty of opportunities to become involved. But let me move on and talk a little bit about health literacy in general. So this is a diversity and inclusion conference, and some people might say, scratch your head and think, well, what is this about literacy? So it's easier to see when I'm talking about refugees, but we could also think about people who do not understand health information for a variety of reasons. It might be because you don't understand English, but it also might be because you don't read well, right? It might be that you don't have access and you don't understand how things are working, right? So in one of the biggest health literacy studies, we have found around the country that about 36% of people in the U.S. do not have enough health understanding to understand and read a prescription label and take that prescription correctly. So think about that minute. 36%. In Kalamazoo County, that means that every chair on this campus could be filled with people who cannot do that. So it's 25,000 people in Kalamazoo County. So if you are doing some clinical work in Kalamazoo County, or you are a case manager, you may think that you're delivering health care, but they may not be receiving health care. So health literacy is a very important element that we need to include people who are not understanding health information much more. In other studies, we found things out, these are even more shocking things, that 60% of people do not understand your typical informed consent. So, is it an informed consent? Not really. And then, I don't have any statistics on this, but think about informed consents that we use for research. We have started to rewrite some of those so that they're more plain language, but are we really giving people what they need? And that's an important information. In that same study, they found 84% of people did not understand the rights and responsibility statements for Medicaid. So, and for those social workers among you, if you've looked at, Medicaid applications, they're extremely difficult to do. So there are many, many areas in health literacy that we could be addressing. So what is health literacy? Health literacy is basically the ability to obtain, understand, and use health information. So it's easy to see that if somebody doesn't have good education, perhaps they would not be able to do that. If they don't know English, they may not be able to do that, right? But so our approach is, like I was just telling you about my English Plus Health program. That is an approach to help people raise that literacy level in one way. But there's another element to this. So what I'll see if I can do this holding this, but if on one side we can raise people's literacy level, but all of us as health providers can also approach this from another angle. And that angle is to take this information that we give to people and make it more plain language. We're not going to change that for everybody, right? So some of my people who don't know much English are still going to struggle. We have interpreters, we have other ways to approach this. But that plain language is a really good start. That plain language needs to be in everything that's written. The average patient information is written at an 11th grade level. The average literacy level in the US is 8th grade. So that's less than half will understand those, right? We also need, and think about all the written information we have. I already mentioned consent forms, but patient education forms, things that you sign, directions in a hospital. Our local hospital, for instance, the doctors say to people, go to the labs, go get your labs. There is no sign in Bronson Hospital that says labs, not one. So you can't find that, right? So it's outpatient testing, different material. So using that plain language in what we do for written information, also our oral information, how we talk to people, practicing. This is all harder than it seems, right? We spend many years in school picking up vocabulary And then I'm saying, well, change that vocabulary, lower it. I'm not talking about dumbing down. I'm talking about giving plain language. And everyone in this room has had an experience where you've gone somewhere to, some health situation, maybe the mechanic, maybe a lawyer, and you don't understand a word they're saying, right? Because they have different kind of language than you have. So changing that information is important. Checking for understanding, particularly when you're working with somebody individually, checking that they actually understand the information. And not just saying, do you understand? Because everybody will nod their head, right? But checking, actually having, and what we use in health literacy is called teach back, and some of you know of this, but basically having them kind of tell you what you have talked to them about. And also the other thing is adjusting your language to fit the audience, using metaphors and examples, language, information aids that fit into that audience. If you look at what happened in the pandemic, a lot of our information did not do that. We did not give the right information to the certain audiences, right? And we, suffered from that. Some of that was also oral information, right? So there are plenty of things to do with health literacy that don't mean that you have to teach somebody, an immigrant or somebody that's do some tutoring for somebody that has low literacy issues. So the good news is all of those things are fairly challenging to do, but the good news is that there's plenty of resources. The CDC has resources, the ARC has resources to help you learn plain language. You can also hire somebody to help you with that. Literacy centers, for instance, are good for that, that will help you to put things into plain language. The University of Michigan has a whole repository of patient education that is in plain language that anybody can use. It's Creative Commons. There are training programs. There's a new one with the Institute of Healthcare Advancement. I served as a content expert for their certificate program. So they have a certificate program that leads to a health literacy specialist. You can take it's mini courses, and so you could take some of them if you just want to learn plain language for oral presentation and teach back. You can do one on that. You can do one to make organizations health literate. So literacy-friendly organizations are another element we're really looking at, is changing organizations so that the whole organization is more friendly to people that are struggling with understanding and using health information. So I wanted to mention all of those things. So there's local area ways to get involved. English Plus Health, come talk to me. I'd love to some volunteers. There's internship opportunities at Kalamazoo Literacy Council. There's opportunities for classes to help at the Kalamazoo Literacy Council. I also am the coordinator for the Michigan Health Literacy Coalition, and this is a group that gets together once a month and talks about what we're doing in health literacy. For instance, right now, a lot of hospitals are rewriting a lot of the patient education or, the informed consent. So there's a lot. It's really a beginning field that I think is going to develop more, so that there will be people that are actually their whole careers in health literacy. So inclusion to me means including people that even if we cannot recognize that somebody doesn't understand when they walk through the door, using plain language will give us a better idea, and using teach back will give us a better idea. So I kind of wanted to make this a little bit larger than just, my pet project of my Health Plus English program. So, questions?
I have a question.
Yes.
When does your program run? What is the time frame in the summer?
It's July through August. We're expanding it to 7 weeks this year. We've done 5 in the past. And we're doing a morning session, 3 different levels. We're also hoping to do a level for pre-literate, people who are learning English, as some of our Afghan refugees in particular are unschooled as well as not knowing English. Yes?
Are you preparing for Ukrainians?
So I'm not sure they'll be here by summer, but perhaps.
Some of the other programs, is there anything that we can?
Oh yes, so I should mention that Kalamazoo is one of the cities that brings in more refugees than other cities in Michigan. And we have a couple of placement groups that work with refugees. The Kalamazoo Refugee Resource Council, if you're interested in working with refugees, that's a good place to start as well. So you can look that up online.
Thank you. There you go.
So, yes.
Is this all English as second language?
The program that I have in the summer is English as a second language. The Kalamazoo Literacy Council has literacy learners and English language learners.
Thank you, thank you.
I did get an email from Thelma, sorry. Give me a 2-year habit. I did get an email from Thelma Hendershot, and she is ill, so she's coming. So that gives us about 9 minutes extra. If you have a question for either of the panelists and you didn't get your question in, feel free to ask a question. If you have a question, it came up in your head later. Anything at all? Yes.
Yes, we do.
Can you repeat the question?
Oh, sorry. She asked if we utilized community health workers or CHWs with Greater Kalamazoo. And the answer is yes. And some of the work that we're doing now is ways to further integrate CHWs in the wonderful work that they do in our different institutions and programs. So there's a lot done within our medical institutions, but we recognize that the importance of CHWs, home visitors, as well as doula support for our healthcare systems is important. So those are programs that we are utilizing. We actually have someone in the room who works with Credo and CHW and doula work as well. So that is a model that we utilize, and we also promote. We promote it and encourage providers to promote as well, kind of like prescribing it, right, as something to be utilized for our community members.
Thank you. We have another question.
And I was going to ask the same thing for you, Doctor. If you knew about the community programs that are here. As a community health worker last year, I worked with 7 of the pregnant homeless people, pregnant homeless women. So I was out there a lot with loaves and dishes in the tents with people during the pandemic. So I wondered if you knew about that or if you can help people.
I know about it through my practice actually, just over the last 3 years, and I know I've gone out once with the First Family Partnership, and I know about Healthy Babies, Healthy Start, but we were talking about earlier, like, it's so hard sometimes to access the programs, even if we know that they exist. We know that they exist, but like really knowing how to connect our patients to them is like we're trying to get processes that are easier for clinicians to follow to connect them. So please email me.
Thank you. Are there any other questions?
I'm sorry, was the question directed to me, and if so, would you mind repeating it?
So I wonder if folks here are familiar with what community health workers are and what the training requirements would be and the benefits.
And I'll ask
Sogna to jump in too, because she's gone through this and has that direct experience where I am not a direct provider. But community health workers are essentially another member of a care team, and they help to not only educate community members or those working with them, but to help them to access services and get the needs that they need within our community. An important part of community health workers is that they are community-based, right? So sometimes folks are not always receptive to those that work within larger institutions. Sometimes things associated with pedigree, but community health workers are truly community-based folks who have the best interests of the folks that they're serving in mind. So again, connecting them to resources, making sure that they understand things like informed consent and that they have all of the resources that they need for themselves and for their families to have to acquire the best health equity. So, and I think the important thing that I'd like to say is stressing that they are part of a care team and can serve as part of the care team even if they operate outside of our larger institutions, whether it's grassroots or some of the maternal health, infant health programs, or things like Dr. Lori mentioned, Healthy Babies, Healthy Start, Nurse Family Partnership, whatever the modality, but making sure that they are integrated into the care that folks are receiving, and that people in these larger institutions are utilizing them as resources. And we have resources available that help to educate folks on community health workers, and also to kind of address some of the misconceptions that can be associated with community health workers or home visitation programs and different things like that. I'm sorry, did that answer your question?
Yes.
Okay. So maybe you want to, sorry, I'm
Sure.
breaking rules.
So in addition to what Joy just said, who we are, I am a perinatal counselor, I'm a doula, I'm a lactation consultant, I also work at Bronson. There are social workers, there are nurses. So we work within an organization. I work with Healthy Babies, Healthy Start, and we've joined different groups with the degrees that we have, and we go out and we work in the community, home visiting programs, reaching into the other organizations that are there, but we go and work specifically with families in their homes, or meet in a different environment, maybe a coffee shop or a restaurant or in the park, wherever they feel more comfortable, and we connect them to community resources, keeping their bills paid, making sure that they know how to find money and resources to help with their child care, bringing diapers, the YWCA, and things like that. So anybody could do it. It's getting involved with another organization that is the umbrella of that.
So on that, so you work for Bronson as a community health worker?
I am a lactation consultant, but Bronson has community health workers. Well, they're not social workers. Moa Stell, who was here last night, she's a community health worker. She works in Bronson Women's Services, connecting them in when they come and do their intake for community care.
Who else in the community?
Cradle has a community health worker, and we just launched our Universal Access, which is something we are putting in place to help folks access and navigate resources where there might be difficulties. So Greater Kalamazoo has a community, her name is Mary DeMoss, and she's serving to kind of eliminate that disclosure piece that may make folks uncomfortable and may persuade them not to utilize these resources that we know are heavy in our community. And also community health worker as a model. There are a lot of different names that can almost be used synonymously with community health worker in different institutions. ISK has community health workers now. I believe Borges has them, but they may call them, their title may be a little bit different, but the role and the job and the purpose, especially connecting them to resources, is still available. So those are a few institutions that I know have community health workers or someone out in the same type of role.
I was just going to mention that Intercare also does.
Thank you. We've come to the end of the panel formally, but now we're going to have Dr. Carla Chase to debrief us. So what next? What now?
Hi, everybody. As Ron mentioned, his schedule was a little crazy today, so I'm stepping in for him. My name is Carla Chase, and I so appreciate all the speakers and the activists and the organizers and the students who shared. I think sometimes these conversations, well, when they're done well and we share, impact our heart. It gets weighted down and it feels heavy when we recognize all the work that still needs to be done, all the disparities that are still there. But when we hear about all the great programs that are happening and the different groups that we see with students out, and there's a little glimmer of hope too. So which makes our heart feel a little lighter, so that's a good thing. But when we attend these events, I think it's really important that we reflect. We reflect on when we're getting ready to go into a situation, what am I bringing to that situation? I'm reflecting on who am I and who am I bringing into that situation. In the moment, we reflect on what are we doing in this moment? Are we in the moment the way we should be? What are we recognizing and what are we seeing? And then after the encounter with our clients or whomever, we reflect on that and say, were we our best selves? You know, what could we have done differently in that situation? So I think when we attend these events, I think there's a reflection time that has to happen. So here's kind of the call to action. Share, first reflect, just a couple minutes, like what are your take-home nuggets? What can you do tomorrow in your personal life, because it's Saturday? What can you do Monday when you're with students, or Tuesday when you're in the clinic? What can you do to make a difference when you recognize disparities and challenges? So take 5-10 minutes, reflect, come up with 1 or 2 take-home nuggets that you feel you can apply right away to the way you interact. Brief personal story, I was talking with someone recently and we were talking about how do you get through dark times, right? Everybody has their, when I was a child, we used to sing the song, This Little Light of Mine, right? Some of you may know it, but it's all about just what can you do in that moment? What do you bring? How can you make a difference when times are dark? And how do you help others and help yourself? So that little light that gets out there. So it's one of those action items. So some specific and generalities, share with your table, and then we'll just have a few that we share as kind of a wrap up. So thank you. We'll check back about 10 minutes.
Not too much, but enough.
not, I'm sure it was. But.
Thank you all for coming. We appreciate it.
Oh, well, my name's Eva. I actually came, I'm in a school because like our teacher was offering us a credit, and we just came like to get our like that's why I just came. Like I'm glad I came because I definitely I don't know, I learned a lot. It was nice to meet that neighborhood. Like even though like when they're in the program, like obviously you guys talk a lot about it, but I was also glad that like I was talking about that student who wrote a letter that they actually did letters like that, and actually like, he was a help player. Like they didn't just disregard like, oh, they're graduated, like you probably like no, yeah, like I was really glad and like yeah, I don't know, just being like more knowledgeable like on in class and not just like I don't know, because obviously like of course going to classes like oh my gosh I have to go, but it's also important to like be present and see what other people are doing.
Okay, so I'm Victoria. I work in Facebook to be called but also I've always done like social justice advocate, and like advocate for patients.
Oh, wow. I get this is a busy meeting in April because I'm trying to wrap up, but it's not April. Okay.
I was also just here from who's supportive of this and what can we do with the further support to advocate?
Yeah, those were two.
I want to see college.
Yeah, that's what
I'm also on the they're trying to be like, thank you all for
this was the high school. Why did you know that so actually with what sort of or did you get to I think so. I know I haven't done it. But I like never. I don't know what. I think you can pull that up. That's what I like.
would do it with that. Like, I'm gonna introduce myself to my identities and say, like, gender, white, woman, middle class. You know, like, I can help people learn about it's the learning exercise. Like, what are our identities?
I was like trying to go like
Really, so you don't want people to feel embarrassed because they don't know what you're talking about. But yeah, I think that in the beginning, it is like that, like, the best class is working so far was one where there was more of kind of fill up from that. They're probably big now, they're probably 50. Yeah.
I think what you were saying about the whole choice, they want to introduce pronouns and all that stuff. I mean, some people are all that stuff. So I think it should be like a choice. So when you're asking people to introduce themselves, you should ask like, if you want to introduce pronouns, you want to do this, then let's say, all right, guys, let's introduce ourselves. What pronoun? What is this? What is that? You should leave it up to the choice of the person talking about it. And when it comes to like their identity as native American, I don't typically use it. I know how to tell native American, but usually I can keep it to myself. But sometimes in situations, I reserve it just to see what other people are saying without knowing that there's named person around. And then maybe after the fact, I say, like, rethink and consider the environment. But for some people, introducing their identity is very important. And so I think that should also be like incorporated a little bit. Because when you look at someone like me, I think I'm white, and I am white, but I'm also Native American. That's what I identify as. And so you can't always tell what someone is, obviously. And so it's always great to ask. They would like to, yeah.
Have various where would you find access or identities that you don't
And they don't even allow you to even practice holistic health. Like, what you're saying? Meditate. Take time to breathe.
I can tell you that, you know, you're doing the work with casting. I don't know if you want to connect or not, but I can tell you one of the things that we do have to show that our student body is reflective. Our student body is reflective of our population, and that also means being open to other cultures, being multicultural, and so it's all those aspects that we don't have to. I just reading an article published in 2020.
The first thing that happens is like,
and he said, essentially, we just like, you know, you're having your diabetes, but didn't
And then his last name. I would have done the same. So in the place I said now, first is where their bodies. They're not managing well, or maybe they
Not even acknowledging that. Right. I'm like, so this is a way to. No. I'm like, even my cat is treating the it'll feel good. I'm like, this is totally good. It's still needed, right? So, yeah, it's hard. Right? To be the one to say that, to see evidence. And always just do that. So, like, being able to get talk about what that's so there's some there were already some stuff.
Thought about it so much, and then I went back to the normal. So I was kind of like thinking on the fly.
So there's different ways that you kind of look at this. Somebody can watch my actual is I'm gonna follow up with this.
Okay, guys, so think about what you want to share from your table, kind of wrap up your current conversation. You know, it's good to have these little nuggets. We're like students, it's like, oh, they're gonna put us in small groups, but then once we do it, the conversation starts and the sharing starts, and it's a big fun. And I say that as a nerdy teacher. Group work is fun. So I think I'd like to go and ask for representatives from, no, just volunteers. If you'd like to share kind of the nuggets that were mentioned in your group, or what are those take-home action items that you would like to implement, whether in your classrooms, your lives, your family units, wherever. So any volunteers?
We came up with many, but we'll just say we really are going to try to emphasize that feedback are gifts from our students and acknowledge that power differential, acknowledge when traumatic things happen in the greater world. Bring in a lot more guest speakers. Anything else?
I mean, I think that kind of goes along with the checking in on that human level, you know, where the students have other circumstances. And the success of a group really depends on everyone having an equal voice and listening, and that means the equal time to speak. So.
And we talked a little bit over here about creating space for some of those conversations. Anyone else? The one one that I want to do, I think Victoria, she's still in here? She mentioned yes. Can it somehow be added to our course evals? You know, and there are booklets of questions that we can choose from to add to our courses so we can get that feedback. So yeah, I've made a note to do that and follow up on that, so thank you for that.
One quick thing about that is that the Student DEI Committee is working on creating a template that you can just use, like a standard. Then we're working with Dr. McCorkle about that. So it's in process. We're gonna have to come up with a proposal and bring it to Faculty Senate and all of that. But if you know that you want to help with that, that would be great.
And just know, having been on the Faculty Senate in the past, you can ask your students to evaluate anything about you separately, if that makes sense. So if you're eager to kind of see how this might work, you can just say, here's an anonymous survey, go to socrative.com, answer this short question. But to formalize it, absolutely, it'll need to go through the process and Faculty Senate, so they'll actually can be part of the portfolio of the instructor.
You could do that as a student employer as well. I'm not a faculty person, but I do employ students in the IT department. So when you're doing your evaluations at the end of the semester or end of the year, you could do that as well.
So you ask them to evaluate you as a supervisor and whoever's on how those situations are handled or how they felt?
Yeah, we do a back and forth evaluation individually with students at the end of the semester or when they leave us. Unfortunately, when they get an internship or graduate. So.
That's good to know. Thank you. Any other take-home action items that anyone? Yes, in the back.
I'm coming.
So this experience just, I don't know, I guess reminded me that it's really important to help encourage our classmates, not just ourselves, to be educated on topics that are outside of our textbooks and what we discuss in class. We were talking about how the statistics regarding infant mortality and even the med literacy was just shocking, and it's honestly really concerning. And being in a health field, I mean, this is stuff that we're gonna have to encounter all the time, and to not even know about it is scary. And so I don't know, I just feel like now we have even more of a responsibility to really at least try to bring awareness for other people that we're around towards these issues, but definitely to address it for ourselves too.
Thank you. We don't know what we don't know. So getting out in the community and learning how others are experiencing the world can be very powerful. To teach us what we didn't know, right? And then how can we go to use that for good?
Melissa, can I pick on you?
Yeah, I'll take us down. So we were talking about, we talked a lot about the health literacy piece. And so working in higher education and working in multicultural affairs, making sure that as we are really promoting ourselves as an open access institution, that the materials that we have that are available for our families and for our students are open access materials. And so are they able to understand what we're saying? When I read ombudsman, did I know what an ombudsman was before I was working in higher ed? So do I know to ask that person for help if I need it? And so there are probably other things like that as well. If I'm a first generation college student and I'm looking for help, when I look at the directory, can I tell from looking at your title and your description and the vita that's posted, what you actually do and how I interact with that, right? And so since we have a wellness wheel and we have a wellness model that we all work with to kind of inform the services that we provide, how are we making that equitable? And how are we making sure that we are accessible from every angle? And so we were just talking about how that's really low-hanging fruit. That's not something that we have to have a committee meeting about. That's something that we can fix right away and even affect it in a way that we be ready for the next class to come by June. it's quick. And so it's like, you know, if someone brings something to your attention, do something immediately so that you can hold yourself accountable for that. Anything else anyone else want to add?
And then as Pam said, be grateful for that feedback and learn from it and move forward. Any other table want to share? I heard a lot of good conversations.
Just one other, we don't know the backstories of the people that we're working with. So I work with a neurodivergent population, predominantly white. So race is something that is a little bit obvious, but that behavioral health and neurodivergent and gender diverse backstory isn't always obvious, and just increasing our awareness of that.
Yeah, I think even when we were talking about pronoun use, if you're not sure, don't use a pronoun, right? And so that adds to that reflection a little bit, but it's more respectful rather than making some assumptions sometimes. So yes, because you don't know sometimes.
I would say we don't ever know unless somebody tells us. So default to I just default to gender neutral pronouns. If somebody doesn't tell me what their pronouns are, I just use they, them. And then they can say, oh, it's she, oh, it's he. No problem, no big deal.
So there's a tip right there. Well, hopefully you've all had your heart lifted a little bit with some hope and some encouragement and some good works of others. We hope that there's a little more weight on your heart when you recognize the work that needs to be done, but that we can do this. So coming here today, sharing and learning is a very important step. So thank you for taking the time to do that. And for the committee, Dr. Dennis and her team and all the speakers, if we could just do one more round of applause and thank you all for coming.
Grab a snack.
Dr. Dennis said grab some snacks.
Oh, yeah.
Just one other real quick thing is that we're gonna email out an evaluation, probably on Monday, but there's a scan code thing on the back of your program, so you can take it right now before you forget all the things. Thank you.
Absolutely.